लताएं प्रयास करते हुए कुछ समय पश्चात पुनः वृक्ष की चोटी पर पहुंच गए और उनका
Good evening, all of you. Greetings from Aravind Hospital, Pondicherry. I welcome you all for the lockdown lecture series. And today's talk is on OCT, structure and progression analysis in glaucoma by Dr. Pradeep Ramulu, who's Professor of Ophthalmology and Chief Glaucoma Services at Wilmer Eye Institute, Johns Hopkins, Baltimore. Is a great teacher who uses many innovative methods in teaching, including flipped classroom. And he was the one who introduced Kahoot quiz to us, like during his visit to Pondicherry. And all of you will be enjoying a Kahoot quiz on glaucoma, maybe next week. And Dr. Pradeep Ramulu is a great clinician scientist, and his main area of research includes visual disabilities and rehabilitation in glaucoma. He has been associated with Aravind Eye Care System for more than a decade now, and who has mentored many people like me, and who has been a teacher helping us in publication. And we thank you, sir, on behalf of Aravind Eye Care System for agreeing to spare your valuable time and enlighten us on OCT, structure and progression analysis. Over to you, sir.
Okay, thank you, Kavita. Let me maximize my screen. Make sure you're all seeing okay. Are you seeing everything okay?
Yes, sir. Yes, sir. Perfect.
Okay. Well, thanks to all of you for joining us today, and I hope all of you are staying safe. I know it's a very difficult time. I'm sure all of you in India as well. Maybe some of the patients aren't coming. Here we're seeing very few patients, and certainly we still taking care of a few emergencies, but we worry about all those people who can't be seen. And I think we also worry about what's happening to them. And I think we certainly have a lot of concern for our staff and their well-being and how they're going to make do. And of course, for our general society, and most of all, for all the people who are getting sick from the coronavirus. But I appreciate Dr. Kavita and Dr. Annamalai and Ganeshan. I saw you as well. So thanks to all of you for arranging this lecture series. Obviously, it's a nice thing to be able to do something to learn better and to be able to help our patients better when we're able to resume with our normal clinical operations. So I think probably all of you have an OCT machine in your clinical system, and I think OCT obviously is a nice device that's won out as the preferred way for glaucoma imaging, not only because it works so well, but because it's also a very multifunctional device. So some of you may also be using it for other things, such as to rule out macular edema or to be evaluating diabetic macular edema. And so it's certainly a very nice and a very simple device to use. So today we'll talk about OCT for structural and progression analysis. So whenever you see a new patient, I think there's several goals that you have for that patient. So the first thing is, if you're evaluating them in a glaucoma sense, you have to ask, is glaucoma present in the first place? And I think typically this question might have initiated by the appearance of the optic nerve. So obviously, if you have an optic nerve which is cupped to the extent that this one is cupped, then maybe you don't even need an OCT test. But sometimes we see more subtle optic nerve changes, and we want to know, is this really a glaucoma patient or not? And I think oftentimes we're asking not necessarily is glaucoma present, but we're really asking the flip question. Are you sure there is no glaucoma evaluation? So do you need to move on to actually treat this patient as either a glaucoma suspect or somebody who actually has glaucoma? And of course, we know very well that glaucoma can happen in any eye pressure. And so just because the pressure is normal doesn't mean that they don't have glaucoma. And then finally, you want to kind of get a sense of how severe the disease is. But usually this happens after you've made this initial decision of whether glaucoma is present or not. And I'll argue that really severity of disease is probably better judged by ways other than OCT. So for example, visual fields is a very, very good way of judging how severe somebody's glaucoma is. Sometimes you can tell that if there's very severe cupping as well, or if the visual acuity is down. But I think early on in this question of is there no glaucoma, OCT is a very, very useful test. And so I really like this test. It's actually the only test I might get when I'm trying to decide whether somebody who's a suspect has glaucoma, especially in the Indian setting where people may not be very comfortable with technology. So if you have especially the laborer population, if they have individuals who aren't very comfortable doing these kind of tests, you may have a lot of unreliable tests. And so sometimes there's a lot of work to get visual fields, and it's easier to just simply get an OCT to decide whether they have glaucoma or not. And if they don't, you can move on. And if they do, you can do more testing, such as visual field testing. So for this reason, I find OCT to be very, very helpful in new patients. And I work in a specialty clinic, which is just glaucoma. And so everybody gets this before they see me, regardless of anything. So I think it's very useful because in a normal scan, you can say with a very high likelihood that there is not going to be any glaucoma present, and you can be very reassuring towards the patient. And I think this is something that we don't appreciate glaucoma for. You know, glaucoma gets a lot of criticism for what we call red disease, where we tell somebody they have the disease just because there's areas that are graded as abnormal or shown as red on the scan printout. But I think what the OCT also does very well is it takes those people who maybe 15 years ago we used to follow as being glaucoma suspects just because they had a large cup-to-disc ratio. And I think a lot of those individuals who just have a high cup-to-disc ratio, often because they have a large optic nerve head, can be distinguished as not really having glaucoma because they have a very healthy amount of optic nerve tissue and nerve fiber layer. And so a lot of those people we don't need to keep on following. Otherwise, our clinics will be overrun by these individuals who really don't have glaucoma and aren't going to go on to get glaucoma. I think it's also very good at identifying the very, very early stages of disease. So I think in glaucoma, we don't really want it to get to the stages where they have significant visual field damage and functional impairment. And so we really want to be able to identify people at this so-called pre-parametric stage where the optic nerve is abnormal, but the visual field loss is either undetectable or minimal. This is when we want to find the disease, so we don't let people become disabled from their disease. The nice thing about OCT, and this is a key point, is that it does a very, very good job of ruling out glaucoma. So even if you have somebody who is at high risk for glaucoma, and for example, if you have somebody who has a high pressure or has a strong family history, Dr. Kavita has some great work on family history in the past. So if you have such a high risk patient, and even if you know that underlying they have a high risk of glaucoma, and if an OCT is normal, you can say with pretty high confidence that they don't have glaucoma. So this was a very nice study done almost 10 years ago now, and the technology has probably gone even a little bit better. And it shows you how different parameters of the OCT have positively, what is their positive predictive value or negative predictive value at different prevalence rates of glaucoma. So in other words, if you take people who have a low likelihood of having glaucoma, so only a 5% prevalence. So this might be, you know, if you're scanning somebody who's older in their upper 70s or 80s, you're already talking about a prevalence of this level. So if you would just randomly do an OCT on everybody who came through, what you would see is that if you take a simple measure, such as the average nerve fiber layer thickness, you know, the positive predictive value is going to be very low. So in other words, if they have a scan, which is said to be abnormal, the likelihood that they really are abnormal is not going to be very high. So this kind of illustrates the point that I was talking about, the so-called red disease, that and very few of these measures, except maybe the inferior average thickness or the inferior zone, don't do a very good job of positively predicting glaucoma. But it does a really excellent job as a negative predictive value. So in other words, if the average thickness is normal, the likelihood that you don't have glaucoma is 98%. So you can say with 98% confidence that this person doesn't have glaucoma, which is really excellent. So in other words, you can rule them out. And even in those 2% of cases where they might have it, usually they're going to have a very mild version of it. And so you're not missing something which is a very substantial disease. So what about if you have somebody who's a higher risk suspect? So in other words, they have a 10% chance, or let's say even a 30% chance of having glaucoma, just based on their socio-demographic features. Well, even then it does very, very well. So you can see here that at this level, it also starts becoming fairly good at predicting whether glaucoma is present. So that you have positive predictive values in the 70 to 90% range, but maybe still not that great for overall nerve fibrillary thickness. But you can see that the negative predictive value is still very good. So you can tell people that they have a 5 in 6 chance of not having glaucoma based on this normal scan. The other thing I will mention again is that even when you're wrong in those 1/6 of cases, usually you're not missing the very severe disease. You may be missing something which is very subtle and early, and the impact of that may not be particularly high. So there are several, so when you're thinking about what OCT parameters should you be looking at in order to judge whether or not glaucoma is present, a lot of them do very, very well. So this is one study which looked at many, many different parameters. So the rim area, the inferior quadrant, the vertical cup-to-disc ratio, the clock hours, et cetera, but probably the one which is easiest is just overall, what is the nerve fiber layer thickness in the scan, and I'll go over exactly how we look at that in that typical scan in a little bit. But you can see that, when you are comparing a normal scan to a normal eye to an eye with moderate or severe glaucoma, the average nerve fiber layer thickness does really an excellent job of distinguishing whether or not that eye has glaucoma. So it shows this is what we call an ROC curve, where you compare the specificity at the sensitivity at different specificities. And you can see that the test is highly sensitive and specific. So it can really very well, in other words, it can very well distinguish these normal eyes from these eyes with moderate to severe glaucoma. If you look at early glaucoma, it doesn't do quite as well. And so it does miss a few still, but still you can see that there's very good sensitivity and specificity. This again brings out the point, however, that even when it's missing things, it's most often going to miss the early disease, and it's very rarely going to miss the moderate or severe disease. OCT does very, very well, even in picking up eyes that have what we call pre-perimetric glaucoma. In other words, eyes that have glaucoma but still maintain a normal visual field. So they're pre-perimetric. This was a very nice study done about 6 years ago now, which actually looked at pre-perimetric glaucoma and defined this group as eyes that had progression with color photographs, but still had a normal visual field. So they actually had to follow these eyes for several years to accumulate this pre-perimetric group. But the nice thing about this pre-perimetric group is that you can even see, so these are eyes that, if you just looked at them cross-sectionally, you wouldn't even know that they had anything. But they were able to say that they had glaucoma based on several years of color photographs. And what you see is that, again, average or total nerve fiber layer thickness is very, very good and has a high sensitivity and specificity in distinguishing these pre-perimetric eyes from eyes that are normal. So it does a very, very good job, even in this absolute earliest stage of disease, where the person is headed toward disease, but actually still really has minimal, if any, visual disability. Looking to the future, I think there's probably even better ways of judging these scans than the way we're thinking of doing them right now. So everything I've talked to you about so far is just looking at average metrics of thickness in the scan. And I'll show you some scans and where all this information is in a minute. But I think what's very interesting is that probably in the future, we won't be necessarily looking at these metrics, well, at least not by themselves. We'll also be looking at, artificial intelligence algorithms to tell us how well is the scan doing. So for example, deep learning was shown to do better than traditional metrics in this one paper that was just published recently in ophthalmology. And what it shows is that either the thickness map or the en-face image actually does better than either the macular nerve fiber layer thickness or the circumpapillary nerve fiber layer thickness of the optic nerve. And so you can see this green line is actually the most sensitive and specific. So there's more information there than you think. What's quite interesting is that actually if you did a deep learning model on the thickness map of the nerve fiber layer, it didn't do all that well. But what did really well is the so-called en-face image. And so this is almost like a color photographic image. So this color image, or this it's not color, but this photographic image actually seemed to have even more information than the nerve fiber layer thickness pixel by pixel scan in judging how well, whether somebody had glaucoma or not. So let's go through the steps of interpreting an OCT test to decide whether glaucoma is present or whether it's not present. So the first step is always to ask, is the test result believable? And we'll go through the steps that I use to decide that. I'll go through the reliability measures about whether something is believable or not. The next thing is you want to look at like the scan features. Then you want to ask, is the test abnormal? And we'll look at global measures to judge abnormality, which we've discussed some already. Then of course you want to not only, glaucoma doesn't always affect all of the visual field, or I'm sorry, all of the nerve. Sometimes it has a localized effect. And so we can look at regional findings to judge abnormality. And finally, I think glaucoma is often a very asymmetric disease between the two eyes. And so it's useful to use inter-eye comparisons to judge abnormality as well. So let's start off by talking about reliability measures. The main reliability measure to think about in OCT is signal strength. So this shows you the Zeiss OCT scan, and it's worth taking a few minutes just to discuss each part of that. So I think in the top is the patient's information, and then also the exam date and the exam time. And so you want to look at all of this to make sure that it corresponds with the patient who you're looking at. You want to look at the signal strength, which is right up top over here, and it gives it to you for both the right eye and the left eye. And then what you see is the nerve fiber layer thickness map. I also look at this quite carefully. It's quite nice. It actually shows you in a color coding with the hotter colors, the yellow, orange, red, indicating more nerve fiber layer thickness. And what one would expect is that there would be an inferotemporal and a superotemporal bundle, and that it would be fairly symmetric across the midlines. So there'll be that the inferior bundle would be similar to the superior bundle, which of course you don't see as well over here in the right eye, although you do see in the left. It also gives you some overall measures. I think the one that I look at often the most is average nerve fiber layer thickness. It gives you other things such as the disc area, so you're dealing with a big disc or a small disc. Some of the values are not particularly helpful, such as cup volume and cup to disc ratio. I think these often don't agree with clinical impressions that well, and I wouldn't put that much effort into it. Likewise, rim area is not particularly useful as well. And I disregard this neuroretinal rim thickness too. It shows you the retinal nerve fiber layer deviation map. So in other words, at each of these points, how abnormal is that point? Of course, this can be a little bit tricky for reasons that I'll show you. So if the thickness is just found in a different place, sometimes it'll call things abnormal. And so that's not necessarily extremely helpful. And so I actually just like looking at the nerve fiber layer thickness itself as opposed to the deviation map. I think another aspect of the scan, which is very helpful, is the so-called T-SNIT plot. It's called T-SNIT because it runs from, it's essentially unraveling the circle that's been running around the optic nerve head. And it unravels it starting temporally and then going superior, nasal, inferior temporal. So it's essentially unraveling the circle and showing you how things look. And it does so both for the right eye and the left eye, and it shows you what the thickness is by clock hour or by region. And it's also very helpful because it really is very good at highlighting asymmetry. For example, here you can see that there's asymmetry between the right and left eyes in this superotemporal region. And you can see also that within the right eye, there's a big difference between the inferotemporal peak and the superotemporal peak. It also gives you the quadrant thickness. Again, this can sometimes be not that helpful if where these peaks are maybe not where the machine expects it to be. I'll show you several examples of that, although you can see it here a little bit already. For example, it's expecting the peak thickness to be found right here in the superotemporal region, but it's actually shifted a little bit over here. And sometimes that can cause the machine to say something is abnormal in a region or a clock hour when it isn't really. And you can see that a little bit over here as well. It also shows you the individual clock hours and grades these clock hours or normal or abnormal. For example, over here, it actually finds a couple of clock hours a little bit on the nasal side to be abnormal. And sometimes one has to question whether these are really abnormal or they're simply abnormal because instead of the thickness being here, it's shifted out more temporally. And so it seems to be kind of artificially thin in this region. Which is probably what's happening over here as these peaks are shifted out more to the temporal side as compared to the nasal side. So let's talk about signal strength. You see signal strength shown right up over here. Signal strength in this paper by Harsha Rao did actually seem to be very important for how well something predicted. So this is a nice study where they actually looked at the predictiveness of average nerve fiber layer thickness for people with early, moderate, or advanced glaucoma. And they did it for scans which either had a low signal strength in the solid line, a moderate signal strength in the dashed line, or high signal strength in the dotted line. And what you can see is that for each levels of severity, the predictive value of the scan was better if you had a high signal strength. So this is a pretty good measure that it's actually doing a good job of diagnosing better when you have a high signal strength scan. So it's just showing that over here. So we took a similar approach and maybe didn't find quite the same result. We had originally taken an approach in visual field testing to actually predict error. So in other words, how far off a test was. And so we did this first with visual fields where we actually looked at mean deviation as the outcome. And normally, if you look at the individual, you're plotting mean deviation over time. And if you have a bunch of mean deviations, and Jeff and Johannan on our faculty has done this analysis, and you look at what you think that the mean deviation ought to be based on all of their visual fields and their severity and their eye pressure and their surgery, you can actually calculate an error. So in other words, how far off the visual field is from what you would have predicted it to be. And when we did this for visual fields and we looked at the mean deviation error, what we could actually find is that if you had more false positives, the measured mean deviation was higher or more positive than the predicted mean deviation. And the measured mean deviation was lower if you had more false negatives. Interestingly, we often think of fixation losses as a reliability measure for mean deviation, although it really doesn't seem to be one in established visual field takers. We also noticed that things tended to get worse after about 20% error in either false positives or false negatives. In other words, once you get to this cutoff, things start getting really bad. So as you get more and more false positives and more false negatives, the impact on error becomes larger and larger for every additional bit. We took the same approach for OCTs. And so here, instead of predicting mean deviation error, we predicted overall nerve fiber layer thickness error. And what we found is that there is error, but it actually doesn't become that much worse until the signal strength becomes very, very low. So, it doesn't affect reliability all that badly until the strength goes to about 4 or less. So this is on a Zeiss unit. So, and the other thing it shows is that there's often variability in the average thickness, independent of where the signal strength is. And this is data that Dr. Yohannan published in Ophthalmology just this year. So there are other things that predict reliability as well. This include disease severity and artifact. So you can see over here that in this high signal strength zone, the degree of reliability for 1 point change in signal strength is actually greater in moderate and severe disease. So in other words, as the signal strength drops, it drops more in individuals who have more severe disease than it does in people who have less severe disease. So it has a greater impact in that moderate to severe group. This actually shows what the impact of an artifact does. So we'll go over what these artifacts are. Typically, they're segmentation defects. And you can see that this really affects the predicted thickness quite a bit, by about 5 microns. So one question was that, how does it affect the opposite quadrant? So if you have an artifact in one area, what happens to the opposing area of the OCT? And we found that there wasn't actually a meaningful or statistically significant change. So in other words, if you had a superior artifact, there didn't seem to be, at least not statistically, a meaningful change in the inferior zone. And likewise, if you had an inferior artifact, there was no statistical difference in the superior zone, which meaning that if you do have an artifact in one region, it's still worth looking at the other region to see if you can't get any useful information. And those areas may not be affected that much. The other measure that I call a reliability measure is axial length, because I think we certainly see a lot of myopes in our clinics. And what we see is that as RNFL thickness, as the axial length increases, RNFL thickness seems to decrease. However, the reason it decreases is because in a larger eye, it's actually just drawing this circle larger. And because of that, it actually just seems like it's a lower thickness, but it's not really a lower thickness. And people have used formulas to kind of adjust for this magnification effect by taking the inverse of the axial length as an adjustment factor. And what you see then is that there's actually no association between RNFL thickness and axial length. And if anything, thickness actually goes up a little bit with axial length. What about the scan features which tell me whether a test result is believable or not? Clearly, there's several features of the scan that can indicate this. These include excessive thickness from edema, segmentation errors, and where the peaks are. And so we discussed some of these already. So first of all, if you think about somebody who's a uveitic and is, or a diabetic and is prone to retinal edema, this is somebody who I got a scan on with a uveitis who had an IOP elevation because of steroid treatment. But what you actually see is that the thickness is very, very high and extends, kind of in regions that you may not expect, well to the edge of the scan. And the average thickness is, well above what you would see, even though its pressure presented very high. And so you always have to be afraid in these eyes, whether what you're really seeing is true thickness or just, swelling as a result of interstitial fluid in the nerve fiber layer bundle. And you can see that actually showing up here in the scan itself. The other thing that happens what probably happens most often is that you get segmentation error. So it can't figure out where the different layers of the macula are. And so it just shows everything as black because it can't actually delineate where the nerve fiber layer is. And so in areas where it can't delineate that, oftentimes that says that the thickness is 0, which shows up as black over here. And so you see that both in the right eye scan and in portions of the left eye scan as well. If that area extends into the peripapillary circle where it takes its measurements, then it can also affect that, and you'll typically see the scan value going down to 0 in this TSNIT's plot. You can also get focal segmentation errors, even if the scan overall looks good. So this is one from a posterior vitreous detachment. And if that area is right where that circle is, for example, then you can get a focal defect right in that area. And here you're looking at maybe a superior defect in the left eye, which may or may not really exist just because of this PVD. And you can see it here in the deviation map, the T-SNP plot and the quadrant thickness. So, I think we infer where we think that we ought to see the peak thickness of ganglion cell axons based on the map that was created by Ted Garway-Heath. So in a very nice study, he actually traced back where neurofibrillary defects were into the optic nerve. And so you can actually predict where these ganglion cell axons are and where it creates visual field defects as a result. So in people who had these defects, he mapped out where the abnormalities were. And you could tell that he kind of put together areas of the optic nerve head that serve different portions of the visual field. The issue is that myopia tends to move the peak neurofibrillary thickness more temporally. So in other words, instead of the peaks coming where you think they should, right over here, they're shifted out to the temporal side. So in a T-SNP plot, they're shifted away from the midline, so they're happening further to the edge. This brings out another area which is kind of interesting about these plots. Normally, whenever you look at a plot, you want to look right at the middle of the plot for the information. But actually, in this kind of plot, the middle region has the least information. So you actually have to look at the edges of this, not right at the center. And for this reason, some manufacturers have actually gone to looking at the opposite way. So looking at so an end stin plot, so starting nasal and ending nasal. So you can see the displaced peaks. In other eyes, you can see the peaks actually shifted to the nasal side, and this is going to be happening more often in hyperopes. And so here you can see that things are more happening nasally. And so you may actually artifactually see a designation of some temporal regions as abnormal because it's not where it expects the plot to be. The next question is the test abnormal? This is often the main thing that we want to know. So we can use global measures, regional findings, and inter-eye comparisons. So these are the three ways that I use to judge whether a test is abnormal. Global measures like total neurofibrillary thickness, regional measures such as the quadrant values and the differences in the quadrant values, and then finally the asymmetry between the eyes. So what about global measures? So first of all, you have to keep in mind that every machine is a little bit different. So there are differences between the stratus and the spectralis, or the stratus and the RT view, and same thing you would see that with the cirrus and these others. So you can see that these there's variability, and also that if you look at the line here, that there tends to be a couple of microns different between the stratus and the spectralis, and likewise, it's also a couple of microns different between the stratus and the RT view here too. Of course, neurofibrillary thickness also decreases with age. So oftentimes when we're deciding something is abnormal, we have to think about how old the patient is. In a younger patient, you really ought to be getting thicknesses in the 90 to 100 range, whereas you're going to see a lot of people who are still normal, but in the 80s and sometimes even the upper 70s if they're in the older population. So I think it's very useful to look at total neurofibrillary thickness to identify glaucoma. So, typically these people are going to be if they're in their 90s, the likelihood that they have glaucoma is almost none. There is possible that people have very small defects that you would see, for example, like a neurofibrillary defect on clinical exam, and they would have glaucoma. So I think we should certainly look for that. But the chance of it is very, very low. When you start getting people into their 80s or upper 70s, I think it becomes more plausible that they have glaucoma. But I think it's still probably unlikely, especially in the early 80s, especially if you're talking about an older population, a population that might be slightly myopic. Once you start getting into the 70s, I think you certainly have to at least worry that glaucoma is present. And then I think in early glaucoma, at least in the serous machine, you're often in the lower 70s, and in the moderate to severe, you're in the 60s or the 50s, and that's when you know you have glaucoma. So oftentimes, though, when you see somebody come in, and then in the upper 80s and the 90s, if you can combine this with just a thorough clinical examination, you can essentially rule out glaucoma very easily, and the OCT is very helpful for you. Regional findings are useful as well. Obviously, damage in glaucoma is often localized only to one pole, although often it's not completely like that. So oftentimes there's some diffuse damage and some superimposed local damage as well. So this is an example that I showed you earlier where there's clearly a big difference between the superior and inferior zones on the thickness map. It does show that abnormality on the deviation map too. We showed it to you on the TSNI-T plot or the T-SNP plot, but there's a big difference between the right and left eye in the superior zone, and also within the right eye, inferior to superior. And also it shows up on the quadrant analysis too. And finally, inter-eye comparisons are useful as well. So total eye thickness is typically very similar between the two eyes. This is a distribution of that in Don Boudin's AOS thesis. And typically the peak of difference is 0. But most eyes are within 5 to 8 microns different between the two eyes. But once you start seeing differences of 10 microns or more, they're very unusual in a normal eye. So we show some examples of that you see, 116, and that the average thicknesses are pretty normal over here. They're similar over here as well. And you can see that there's kind of generally very similar patterns of thickness between the two eyes. So here it's not only the numbers, but it's also the pattern. You can see how well these eyes are superimposed between the right and left eye. So when you see two eyes that are where the pattern is right on top of each other, I think that's a very, very reassuring finding. On the other hand, when these patterns are not on top of each other, I think that's often very suggestive for glaucoma. So here you can see that there's areas where there's superimposition, but areas where they really diverge quite a bit, suggesting that there probably really is glaucoma in these eyes because there's a lack of that superimposition of that tracing. Sometimes you can also see that like more in one pole than the other. I think that's often especially helpful. So here you can see that there's superimposition, relative superimposition superiorly, but much less inferiorly. Likewise in this eye, there's it's fairly superimposed superiorly, but there's a huge difference inferiorly as well. I think in our primary goal in returning patients is to balance the risk of disease worsening, which would lead to meaningful consequences to the patient, against the risk of additional burden of therapy. So there's really numerous factors which help us define the risk of worsening besides the testing. And if you just look at a nice study here from EMGT, it's several things that tell us whether patients are likely to be getting worse or not. So is the pressure high? Do they have an aggressive form of glaucoma, such as pseudoexfoliation? Do they have more advanced disease, so is their mean deviation low? Do they have a thin central corneal thickness, or do they have a low corneal hysteresis? All of these things tell us that maybe this is somebody who should be on the lookout in deciding whether or not their disease is getting worse. So we should also keep in mind that the best way to predict the future is to look at what happened in the past. So we should think that that if they have been getting worse in the past, they're very highly at risk for getting worse in the future. So to really judge whether somebody has gotten worse in an OCT, if their glaucoma is getting worse for this region, for this reason, you have to actually say that the declines that you've seen exceed the normal test-to-test variability. And the problem is that, the test-to-test variability, even in these very well-done clinical studies, is actually pretty high. So if you look at what the variability is over here, the mean difference is kind of in the several micron range. So, and that's a pretty broad range. If you look at like, so here it's almost 4 microns. And then here, if you look at like, you know, how big it is just for the superior zone, it's actually very high. It's almost 9 microns. So you can really get a lot of variability between two tests done just within a few days apart in terms of what the average nerve fiber layer thickness is. So it can really be as much as, you know, 4 to 5 microns different overall, and within a specific hole, 9 to 10 microns different. So the variability is even higher when you're looking at tests on different days. And so it's difficult to judge the progression on two tests. So you really need to be seeing huge differences, really above about 8 microns or more to be 95% sure that the difference is not by chance alone. So it has to be very, very different. So the best way to judge is really, if you're going to use OCT as a progression technique, you need to be seeing your patients fairly often, and you need to be using the automated software. And if you're really going to be trying to judge progression through OCT, you're going to actually not be able to get fewer tests. You actually need to get more tests, which can sometimes be hard for patients who have a hard time getting to the clinic and coming back for a lot of visits. Luckily, it's an easy test though. And so one practical thing about OCT is that patients don't mind taking it. It's very, very quick. It's easy for our staff. They don't have to be heavily trained to do it. You don't need to dilate the pupil. So it's something which we certainly can do for our early glaucoma patients every time they come in. And I think it's something which can definitely be considered to help us. So the only way you're really going to tell whether things are getting worse is by getting a series of scans. You know, I actually like to just look at like the colored images and to see whether anything has changed. If you simply look at like the heat map over the series of scans over here, you can see that there's regions which have kind of lost intensity, especially in this inferior zone. And so, and that kind of is corresponding with the numbers. And also the scan tells us that the total thickness is going down, but it's not going down to a significant extent. The inferior thickness really is going down. The superior is not. And it kind of color codes these areas as being kind of now maybe getting worse or definitely getting worse. You have to be careful that there's not pseudo worsening as a result of other things. Certainly some people just get worse with age. People who might have had macular edema, if that macular edema goes away, that can appear as worsening as well. But sometimes we just see worse signal strength is getting worse and we don't really know for sure. This is a patient who's uveitic, so may have had some edema, has had multiple surgeries, the cornea is becoming a little bit hazy, but the pressure has always been controlled. So it's really hard to believe that a young person at a well-controlled pressure would be getting worse. But if you look at her series of OCTs, there's a big change over time. So this is over a span of about 6 years. We see things got much worse, but we also see that the signal strength went down, and perhaps there was some loss of nerve fiber layer thickness because of she might have had some edema, which got better. And so we're seeing a massive change in somebody who really, for all reasons, should be clinically stable. So a very compliant patient who always has consistent pressures. So, and if you look at her visual field over this time, you would think somebody who would have lost this much visual field, this much OCT thickness, would have at least some visual field changes. She doesn't show any over here. And so we have to suspect that maybe these single strength changes were causing the problems. So I think we should also look at change in other ways as well. So when we look at our the guided progression analysis plot that's given to us by Zeiss, you know, I look at all of these parameters. You know, the one that I really like the most, besides the one that I just showed you, which gives you the color coding of values, is actually just looking at the heat maps over time and seeing whether there's any evidence. It also does a good job of highlighting those areas of change. Of course, it doesn't show you areas that may have gotten better, so sometimes this can be noise. It will also plot for you the average thickness over time, both in the total region and in the superior and inferior regions as well. I don't look at the change in cup to disc ratio. And we'll also give you a change in what the rate of change. So here it says that the average rate of change for the total average nerve fiber thickness is 1.3 microns. Average change just related to age is about half a micron or a quarter of a micron. So this is probably about 3 to 4 times as much what is normal. And it also kind of highlights where this change is happening on this kind of difference plot. It highlights the location, which is nice, and the trajectory over time. That being said, I think that you do see a lot of age-related changes and changes that you don't necessarily expect. And so it's rare for me to advance therapy based on OCT progression alone, except if we're really in maybe the early stages of the disease where, we're just adding a few medicines. But to really take these OCT data and do something more risky for the patient, such as trabeculectomy, is going to be very rare. So typically, I like to look for visual field confirmation. In early disease, I will advance if there's especially some other clinical features which suggest that maybe the disease is getting worse, such as poor IOP control, if the patient admits to not taking their drops, or if there's other strong risk factors such as a strong family history or other issues as well. So you have to keep in mind also that the OCT thickness will not drop below a certain threshold. So it never goes to 0 because there's other things in the nerve fiber layer, such as glial cells and other fibrous tissues as well. So even with many tests, you can only really judge progression if there's really at least 5 microns of change overall, or about 10 microns are in the superior or inferior region. And continued test is going to be of little value once you get to be around 65 to 70 microns of total thickness, or 70 to 80 microns of inferior or superior thickness. So I think OCT is terrific for diagnosing glaucoma, but it's more of an adjunctive test in judging progression. It's very useful in new patients, eyes that are suspected to have glaucoma, where you can rule it out. I think you use properly and not overcalling people who just have some areas. You can actually have many fewer suspects. You can also help judge progression, particularly in our very early cases. But you really need to do a good job of integrating it with other clinical information in these eyes with early disease. And it starts to lose its utility in people who have moderate to severe disease, where you probably want to spend most of your testing time getting visual fields, either over the whole 24 to 30 degrees or over the 10 degrees. I didn't talk much today about macular OCT for glaucoma, and so that might be one question. So macular OCT relates to the thickness of the ganglion cell and interplexiform layers. On the Zeiss machine, we found that it tends to sometimes be abnormal, even when the visual fields and nerve fiber layer thickness are totally normal. For this reason, I've not adopted it as much because I think it can be oversensitive. And so there is some suggestion I might be able to detect change even in moderate or advanced glaucoma, but I think the progression software for this is just coming out. So if you want to start using it, you can, but right now it doesn't give you quite as much information about progression that it could otherwise. And so I think this lack or kind of, this lack of formalized progression software limits its utility. So if you have any questions, you can feel free to email me, or I'm happy to take any questions if there's any in the comment area as well. Let me see if I can find.
Thank you, sir. Thank you so much for the excellent talk. And I think people can raise questions related to this, or in general about glaucoma, whatever you're facing difficulties in your day-to-day practice. I think Dr. Pradeep will be happy to take those questions. You can unmute your mic and ask the questions.
Hello.
Yes.
This is Dr. Swapnesh from Mumbai. So excellent presentation. I had a question regarding that 22-year-old uveitic patient.
Yeah.
Why couldn't he classify as a pre-parametric glaucoma? And then what was your final conclusion? Why did he have that OCT change?
Yeah, I think this is one of the difficult things about OCT is that often we don't know, so this is pretty dramatic change in OCT over time. And so is it because the signal strength was lower? Let's see. I think that it was our conclusion that the signal strength may have been low, maybe because the cornea was becoming cloudy. and maybe it was misanalyzing what the true thickness was. But really, when you go down to, you can see that the average thickness really came to a much lower level. And so you would really expect to see some visual field defects. And so this is one of the challenges of OCT, is that sometimes you see it getting worse and you don't necessarily have an explanation. And it's difficult to decide what to do with this individual in that situation. Probably all of you have seen, I see Ganesha nodding his head. But sometimes we see these changes and we don't know how to explain them. And so I think I put this case in there just as kind of a warning that you don't want to be overly interpret this worsening in OCT. So I think OCT does very, very well at diagnosis, but sometimes you see worsening that seems to be age-related or signal-related, or maybe in this case it was macular, it was edema-related, but sometimes you don't really have an explanation. And so it's always nice to confirm that worsening with something else. So if her pressure had been much higher at this stage in the 20s, I think I probably would have been forced to act. But in this case, knowing that everything else was normal about her, that she was under good control, I think you have to be more careful.
Thank you, sir.
I think somebody else has also raised the question in the chat. In pre-perimetric glaucoma, do you use RNFL scan alone or in combination with the macular scan?
I think I do get the macular scans, but I think that it is nice because it gives you kind of an independent validation. First of all, I don't interpret it as much by itself. So with the macular scan, I do look at it, and if there is especially some regional defects in the circumpapillary scan, if you see that same region being affected by the macular scan, I often have greater confidence that there's something real. I think the danger about getting the macular scan is that sometimes the macular scan by itself is abnormal, even when the circumpapillary scan is normal. And I think OCT already is a little bit prone to calling too many people as a suspect or early glaucoma. And so you have to be careful that you don't really kind of raise this number even further. Otherwise, you're going to be giving too many people alarm and raising the need for too many people. And I don't know what it's like in India, but there's certainly so many people who we see with real disease that we don't want to be kind of filling our clinics with people who probably don't really have glaucoma very much, or have a version of glaucoma where they're very, very unlikely to lose any meaningful vision. So I do use it and I do get the scans, but I use it largely for kind of confirmation of what the circumpapillary shows. And I don't, and I tend not to overinterpret it if that's abnormal, whereas the regular one is normal. Kavita, do you want to choose the questions that you really like from all those?
There is like someone else who asked, in pre-perimetric glaucoma, will you start treatment? Like when the fields are going to be normal, will you consider treatment?
Yeah, I think you can. I mean, this is where OCT is useful. So, I mean, especially if the OCT is abnormal and somebody, and it's believable based on the patient's other clinical data, such as their IOP and their age and their family history status. I guess sometimes it can be a little bit tricky if you have an abnormal OCT and there's nothing else wrong. I think it's a bit of a continuum. So if somebody has a abnormal OCT and they have something else that maybe makes them a glaucoma suspect, such as a high pressure or disc hemorrhage, something which you can see on the exam, which makes you concerned, a family history, then I think it's very reasonable to start treating them right away. If they have if they have an OCT that's abnormal and a visual field that's normal, but then they don't have anything else that's wrong, it kind of raises my threshold of how abnormal the OCT needs to be. So, if you're seeing something which is kind of clearly, very asymmetric between the superior and inferior regions and also between the two eyes, then yeah, sometimes I will change treatment. But if there's a little bit of abnormality, maybe just, a quadrant which is kind of graded as yellow, then I may not necessarily do anything. I may watch them.
Hello.
And one more question is like for a glaucoma suspect and for regular glaucoma patients, how frequently do you ask for OCT? How frequently it should be done?
I think there's a good argument to be made that you should probably, if you're going to use this test to judge whether they're getting worse at the early stages, that you ought to get it every time they come in. Just because I showed some data on the fact that these OCTs can be variable over time. So I would say as often as you're seeing the patient, you ought to be getting the OCT. Well, I mean, if you're seeing the patient every 3 months, although I think that would be unusual to see a glaucoma suspect every 3 months, you may not need to get an OCT every time then. But certainly if you're seeing them at a frequency of every 6 months or a year, then I would get an OCT scan every time. And people have, Bal Shahan in Canada has showed some nice data that in some ways, instead of actually kind of alternating our tests, so an OCT one time and a visual field the other time, you may actually get more information by picking one test and getting it every time they come in. So every time they come in, get that test. And I think in the early glaucomas, the OCT is particularly good at that. And I like that approach. So if I'm seeing them every 6 months because they're a high-risk suspect, but their visual fields are normal, get the OCT every time they come in, and then maybe every 12 to 24 months get a visual field just to make sure that it hasn't changed.
Sir, does OCT angiogram on a circumpapillary OCT angiogram, does it have any much role in the early diagnosis or maybe in therapeutic aspect?
Yeah, there is some data to suggest that OCT angiography, especially OCT angiography in the circumpapillary region, may be useful. I think it's still probably a bit on the experimental side. I think that it's harder from a technical standpoint to get OCT angiography images. And really to get the best images, you probably ought to dilate your patients. And I think that's one certainly downside is that we don't want to spend time dilating our patients, and the patients also don't prefer dilation as well. So I'd say right now OCT angiography is still experimental.
Thank you, sir. Thank you.
So there is one more question regarding how will you assess intraocular pressure in patients with adherent glaucoma?
Yeah, I mean, I think that, I think there's probably several ways of doing this. I mean, I think probably most clinics in the US are still using Goldmann applanation. Although I think now with coronavirus, people are sometimes using these, rebound tonometry, just so that there doesn't have to be anything which touches the eye. So it's a little bit better. But then there is a cost to that because we have to constantly use these tips. And so in the Indian setting, it may not be practical to be doing this because the costs become kind of prohibitively high. I think non-contact is also a very reasonable option. In fact, there's some data to suggest that it might be a better option. Felipe Medeiros has shown that actually the corneal compensated IOP from the Reichert non-contact tonometer predicts glaucoma progression even better than Goldmann applanation tonometry. So it may be that some of these more sophisticated non-contact algorithms can actually do even better. So I think as long as you use a consistent method, it doesn't matter. But if I had to say what is maybe the standard, I would say the Reichert non-contact is very good, and then also and I think also Goldmann is something which is certainly quite reasonable as well.
I think there are a few questions from the viewers who are watching the talk through YouTube also. So one of the question is like, how will you use OCT in tilted disc and myopic disc?
Yeah, well, it's very tricky, because oftentimes the myopes, as I showed, will have an artificially thin neurofibrillary layer thickness. And I think the macula is not quite as affected. So that's one area where the macular scan can be more helpful. It turns out that the thickness of the macula is not as affected as the circumpapillary thickness. And so in myopia, I think the macular scan can be a bit more useful. Honestly, I tend to downgrade the meaningfulness of the information that's derived from OCT in myopia. I think that oftentimes what the real thickness is going to be different. And when you think of these algorithms that have been used to generate what you expect neurofibrillary layer thickness to be, they were generated on people where myopes were excluded. So it's not going to really apply. And so unless I think some machines like the Spectralis, for example, you can actually enter the axial length and then it'll give you a corrected value for things. But I think most of us are not routinely measuring axial lengths on people unless they're really coming in for cataract surgery. So we're not doing this as a matter of course in all patients, getting axial length measurements. So I think that, honestly, my answer is that I look at it, but I try and adjust for it, and I tend to down value that information. I value other pieces of information more, such as the visual fields or the eye pressure.
Yeah, thank you. And maybe a final question, we know the comparative data in OCT is available for only the age group of above 18. So below 18 years, we don't have comparative data, but still, would you like to use OCT? I mean, where will you place that?
Say that again?
So in patients less than 18 years,
Yeah. No, that's a good question.
does not have comparative data.
Yeah,
So,
I think in the young patients, what I like to do, let me see, it doesn't give you any normative data. And so what I actually do in those eyes is I simply look at the superior and inferior quadrants, and I look at those, and if they're both greater than 100, I consider that to be a normal scan. And then the total thickness should probably be at least about 80 or so in a younger, probably even higher, 80 or 85. So but the simple rule of thumb that I use in a younger patient is that if the superior and inferior thickness is both greater than 100, then it's normal. And so that's probably a very simple rule of thumb that's not very difficult to remember.
Thank you so much. I again take pleasure in thanking you on behalf of Aravind Eye Care System and all the people who got connected through YouTube and Zoom. It was really, the talk was enlightening. Thank you so much for your valuable time.
Thank you all for joining us. Good luck to all of you, and I hope everything gets back to normal soon for you.
Thank you.